Members, good morning. Good morning, members. Good morning again, members, and welcome to all present. I'm pleased to see so many members of the committee are here in person, and also thank you to our department officials. I'm not sure whether we have anybody in the audience online as guests, but we'll proceed. And we'll do so by me asking the members present to introduce themselves.
Good morning, Chair. Good morning to the officials. Good morning, everybody. My name is Christopher Fry, and I'm a member of this committee.
Thank you, Chair. Morning, Chair, and everyone. My name is Rachel van Voorgang.
Good morning. My name is Dan Plato.
Good morning, Chair, and everyone. My name is Ayanda Barnes.
And if I could ask the department officials to please introduce themselves.
Good morning, Honourable Chair and Honourable Members. Carol Dean, Director in Department of Health for Specialised Hospitals, that includes psychiatric hospitals. Thank you.
Morning, everyone. Miranda Rulofse, and Deputy Director working with Carol in Specialised Hospitals.
Thank you and welcome. I'm not sure, are we aware of any members of the public in attendance online? If so, please introduce yourself. It doesn't seem like it. We move on to apologies. One apology has been received, and that is for Member Klaas, who has indicated that he's involved in other business. And with that, members, we'll move on to the presentation. And thank you for making the time, and thank you for preparing the document. We look forward to the presentation of this very serious matter. Thank you very much.
Thank you so much. Just to say that we were invited here in September of last year. So some of this might sound familiar, but just bear with us. We just want to provide context, especially for those who have not heard this presentation before. So thank you. So we'll be doing an update on our mental health strategy and strategic direction. Thank you. Am I able to move the slides from here? Where do I do that? Oh. Is it okay? Okay, I'm very happy to do that. So that's just some of the areas we'll cover. We won't dwell on it, but we'll just give you our strategic focus, and we'll move on to wellness, and we'll look at some of the extra resources that we've been granted by our Provincial Treasury. So thank you. You may move the next slide. I think it's important to note this is really our rudder, it's our vision. And our vision is access to a person-centered quality care. And our mission is to undertake to provide equitable access to quality health services in partnership with the relevant stakeholders within a balanced and well-managed health system to the people of the Western Cape and beyond. I think this just augments and gives us the focus of where we're going, and it's important just to note this. And our values, we've had it for a long time, and we take it very seriously, that of innovation, caring, competence, accountability, integrity, responsiveness, and respect. And we try really to embed this in our culture. A few years ago, we committed to our strategy and strategic direction of Healthcare 2030. And that really changed the focus from our previous strategies, and we'll speak to it. And alongside that is a community-oriented primary care approach to further support it. Thank you. So just on Healthcare 2030, the focus of Healthcare 2030 is to have a person-centered approach, and you'll note we don't just talk about patient-centered approach, a person-centered approach We think the importance of this is to look at the whole person across his or her lifespan. So it's a life course approach, and increasingly we've been embarking on our strategic planning around this area. And integration is of the most important significance, and especially when it comes to mental health, that it has to be integrated into the rest of the service. And then, of course, continuity of care. So this is a long-term strategy. It's not a quick fix. And this is part of the journey we've embarked upon, which is a wellness approach, rather than just to see mental health as a disease or health as a disease. And part of this journey and part of the focus is to just value quality of life. And then also that we as a system cannot do it by ourselves. It's fine, you can leave it there. That we have to work in partnership, be it with the person seeking care or with other departments. I think that's the focus of Healthcare 2030. Just wanted to make the point of a life course approach. It's before birth to elderly years of our lives. So we see ourselves as interacting with the people of the Western Cape at every significant point in their lives. So just to talk about the life course approach very quickly, is that sometimes sorry, you can go to the next slide. The life course approach, for most of us, we are mostly healthy. And then in between, we might have that defined episode where we need care, and we're trying to look at what does that mean. And then there's a part of our communities who need long-term care. It doesn't matter if you're talking about mental health or other health situations or conditions. And then there's also an area where you have people in the area who have chronically disabling conditions, and what's our response to that? So in the recent workshops, we've really been looking at that as a focus point. So for most of us, we're mostly healthy, but when we do have an illness, a break an arm, or have a situation where I'm depressed, what do I need at those points? And what do I need to give that particular person to get him or her back on track again? So we're trying to see this life course approach as the most important part of what we do, so that we can focus our attention where it's needed most. Thank you. So if you can continue, I think this is what we emerged with, especially after our experience with the hard lockdowns in COVID, that health is everybody's business. We want to support people to live healthier and longer lives. I think we understand that just giving pills is not the option, that we must work at the level of community with people. We want people we serve to know that they matter as human beings, as humans, and we want them to feel optimistic and a sense of worth when they engage with our system. And we aspire to be a health system that is people-centric, as we were saying before, that people trust and that is equitable. Now there's work to be done, and the work that we're doing now helps us with this area, taking resources to where it's needed most. Yeah, we want to be competent and caring, and we also want to have an empowered workforce, because it's one thing to care for our clients, but it's quite another thing to care for our staff, and we don't see that as separate. We're also very committed, I think we just need to say, around our own internal governance and innovation and accessibility to service delivery. And we want a health system for all of us, for you, for me, for everyone. So our goal is to provide the right care at the right time, at the right place, at the right price. That puts our people first. We must understand that this requires us as a department to behave in a particular way. So it's what we do, it's who we are, the be is important, and it's also we talk about being, what it all entails, and I'll share some more of that. Also, another shift is that we realize that communities and community members are critical in the work that we do and part of our partnership. So just again, with the experience of the pandemic, we've come out with a reset agenda. Sorry, next slide, please. I can talk because you've got copies in front of you. Okay. And part of what we've come up with is very much about do, be, and become. And part of the do, as we said, was the right service, right care, right place, right price. But also we want to be a particular system in health, a system that's resilient and connected to values and value-based leaders. And we also see ourselves as being stewards in a bigger relationship, in a health system, within a community. We aspire to becoming a people-centric, trusted, equitable health system for society. So we've put a lot of emphasis on the change of culture that's needed within our department, because we think that that sets us up well to be the stewards that we hope to be. So just getting on to mental health, it seems like the slides can't continue there. Right. The next slide, please. So mental health is defined as a state of well-being where an individual realizes his or her full potential to cope with normal stresses of life and is able to work productively and able to contribute to his or her community. Part of the focus of mental health in the World Health Organization's direction is that we need to see mental health in the context of being population-based. So to see just the individual is not okay, but to see where the person comes from, what's happening within that society. We also need to use evidence and knowledge to support our interventions and our public health approach. And part of what we need to do is engage on all various levels and dimensions, and it includes the political front, economically, socially, on all levels. It's important. The objective of achieving equity in mental health and mental health care includes having a primary health care approach. So I shared with you as a committee that I'm the director of the specialized hospital. So that's the hospitals we all seem to know in the Western Cape, in the metro. So it's Alexandra, Lentegeur, Stikland, Valkenburg, and a lot of the care for mental health used to be at that level before. And what we're really trying to do, and we have been doing, is to bring care at all levels, like the district hospitals, the regional hospitals, primary health care. So people can access services to the closest point, not come up from a community straight to a specialized hospital. So that's really the emphasis, that when we say that we want to have an integrated and primary health care approach. And whatever we do in mental health, we have to include promotion of healthy lifestyles. We have to include prevention of mental illness. And of course, there will always be an aspect of treatment and rehabilitation. So as we said previously, mental health isn't a standalone. It cannot be separated from physical health. It needs to be integrated into the general system. So just to share with you a continuum of care, that we've all known someone, if not ourselves, that you could meet someone in crisis or struggling with mental health related issues, some people just surviving, and then you get people, even though I've had a mental illness or I have a mental illness, I could thrive and I could excel. And we really want to push our society to be part of the green bars, where we all commit ourselves to having a thriving community who excel. So a little bit of anxiety, we all understand that. We understand that sometimes we could get depressed about things, but what can we do to move you on from being in crisis, from struggling with a mental illness? And that's the kind of language and focus we choose to use these days. Thank you. So just to get to the burden of mental illness, so there was a study done, my colleague shared this with me, from the National Income Dynamics Study, and they looked at what was happening pre-COVID and post-COVID. And when I say post-COVID, we're still in COVID, but past the hard lockdowns before our vaccines. And they found consistently higher rates of depressive symptoms during the pandemic. 24 to 29% of people they screened positive compared to 21% pre-COVID. So we see that since COVID, there's been an increase in depressive symptoms. And 52% reported ever experiencing depressive symptoms. So 52% of their sample said at some point, I felt depressive symptoms since the start of the pandemic. And there was a strong link to hunger, food insecurity. So children with fewer depressive symptoms didn't have problems with hunger, compared to children who had issues with hunger would feel more depressed, which makes sense intuitively and otherwise. So self-assessed, self-indicators found that people who were considered to be poor individuals reported ill health more so than people who seem to have less financial concerns, seem to have reported depressive symptoms. So that's also an interesting finding. So a prevalence study was done in the Western Cape a while ago, 2005 I think it was, so it's quite dated, but they found at the time that the prevalence in the Western Cape had a 12-month lifetime prevalence of 39%, and anxiety disorders was 19%, mood disorders 14%, substance disorders 21%. And we'll see later on when I show you some stats how some of this has increased. Suicides, also a worrying trajectory, and we've seen an increase since April 2020. We don't have updated stats since that, but I'll share what we have with you. But we also noted that there was a huge unmet need, and 1 in 4 people with a mental illness would seek assistance. So this is just, when we talk about the unmet need, it's often the person who is depressed or anxious, sitting at home, who choose not to come out for the assistance that could help them, and they could easily be helped if they had presented themselves at a clinic. So we're aware of that. So the next slide is just some of the data we have from our forensic pathology services, where we see the suicides. This is completed suicides, and this is the period from January 2019 to December 2021. And what is worrying, we had 2,188 deaths due to suicide. And you can see that in 2020, there was a bit of a low, and then it started going up again. So we are aware of this, and we're also aware of our young people who are experiencing very difficult times. So just some mental health data, just to give you some context of what we're seeing in our services, in our hospitals. You may move that slide. Thank you. Next one. Next one. Okay, so these are new admissions in our services. So if you look at the left of the screen, 2015, these are new admissions. And you can see by 2022, just the step ladder going up. So we're increasing, and the light blue is for females, and the dark blue for males. In the next slide, these are admissions that we're seeing in our hospitals, the district, regional, and the specialized hospitals and tertiary combined. This is for substance-related admissions, also increasing. If you go to the next slide, please. This is a colorful slide, but it just gives you an idea. If you look at the right of your screen, you'll see the red block, and you'll see how that becomes a bigger proportion by the time we get to 2022. And that represents substances, the red block. So we always know we're going to have a group of people who have schizophrenia, because that's like, we've always been accustomed to that in psychiatry and mental illness. And that group is quite stable if you look at it, and even decreased. And we see the numbers for substances increasing, and that is worrying. So I just thought I'd take you to a slide to say what mental health health services we currently have. So we provide services at a primary healthcare level, where it's a generalist service, where we have medical officers, and we also often have a mental health nurse in a community health center, which is part of the primary healthcare level. Then we also provide services at our district and regional hospitals, and this is in line with our Mental Health Care Act. We have 3 regional hospitals in the rural areas, that's Paul, Worcester and George. We have a regional hospital in the metro, which is New Somerset, and the rural hospitals have dedicated mental health wards. Somerset too, but Somerset runs very much on the acute, similar to the district hospitals in the metro, and all the services are full all the time and even over their 100% occupancy. Tertiary hospitals that provide mental health services is Grooteskier, Tygerberg and Red Cross for children, and then the psychiatric hospitals I shared with you is Alexandra for persons with intellectual disability in the main, Lentegeur, Stikland and Valkenburg. And part of the service areas that we provide is child and adolescent services. We also provide services for persons with intellectual disability. There are small units of therapeutic services. We have an opioid detox and an alcohol rehab service at Stikland, forensic services at Valkenburg and Lentegeur. Last year, we also increased our psychogeriatrics, that's the service for older persons. So we've got a unit at Alexandra now, where it was predominantly at Stikland before. And all services, including tertiary, generally provide OPD services. Now, in addition to the facility-based services, we also fund many NPOs providing services to persons with a mental health condition or persons who need accommodation because of their mental health condition, and we do that in combination with our partners, social development and others. So that's just to give you an idea of where services occur. So we adopt a two-pronged approach, and we understand that we must manage and address the burden of disease, but we also know that we can't do this alone. Department of Health cannot do it on its own. So part of it is to work within a framework of a whole of society, whole of government approach. And we've been actively working in this area. I'll share some more. And as I said at the beginning, we have a community-oriented primary care approach. We just signed off a circular in the department. And really it's about using community health workers to be amongst the community, to support community who have any health condition, but we've included mental health as well. So that's working within a defined geographic service area, and we work closely with our NPO partners in this area. Just another policy that we've also signed into effect, which was late last year. If you can just change the slide, please. It's called Make Every Contact Count. It is a counseling project, policy and program. And we have to come up with an implementation plan for it. But generally speaking, we want to have every encounter that every person has with the health department to be significant in some way. So we're looking at messaging, we're looking at how to support people. We looked at our values and our culture journey that we're on. We really want people to feel a sense of worth and validation when they have contact with the department, that there should be no blame and shame, but that we work in partnership with how to get through a difficult situation. So just looking at the prioritization, if you can continue please, of mental health. So in 2022, February, our HOD, Dr. Keith Kluti, he initiated through the province a steercom for mental health, which was the first that I've ever known of in my career. And he has other HODs who co-chair and support him at that level. Departments of Basic Education, Social Development, DCAS, Department of the Premier provides the governance, and local government is also presented at that level. And the idea was to look at the burden of disease in mental health and to see how we can jointly work towards it. So part of what we did back then in February on we came up with a theory of change for mental health, and there were actions associated with that. And part of the actions were, firstly, the goal was to have a resilient, the resilience and well-being of our citizens of the Western Cape. And part of it was that we should work collectively and jointly in geographic service areas. So we've got 2 pilot sites. We started our mapping exercise in Witzenberg. We also started a mapping exercise in Klipfontein. We're working in the Nyanga and Gugulethu areas. And we have since completed the Witzenberg process, and we're busy concluding the Klipfontein process. We've also begun an evidence advisory committee so that we can start using evidence-based interventions in order to offset some of our difficulties. We're also looking at a communication strategy. So we're doing quite a lot of work in that space. It's a year later, and we're hoping that this will expand and it will grow in momentum. I think what was good last year, we received 30 million from our provincial treasury, and this financial year we received 72 million, and that has been really great. So in all this, we also need to be compliant to our Mental Health Care Act, especially with an acute admission, and we are working on that area as well. So if you can just go to the next slide, please. So I just thought I'd share with this committee some of the new investments that we have. So we call it Project 1, Strengthening of Mental Health Capacity, and this is using our 72 million we just received. So 43.8 million will go into primary health care. So we'll have additional registered counsellors coming on board. We'll have additional OTs coming on board, some social workers, I seem to think, across the province, as well as mental health nurses. And the last time I checked, that works out to about just over 60 posts throughout our province at primary health care level. Then Project 2, we got some money to just support NPO funding because there was inequitable funding across the province, and this is primarily in the rural area. We'll be able to address that issue. And then Project 3, last year we received money for mental health beds for children and adolescents. This year we received money for it again. And we also received money for George last year, 10 beds, and we've got ongoing funding, so that's good news. And then our last project is the Child and Adolescent Strengthening Project, where there's a team of people working towards a training program, package of care, so we've been supported with that as well. We also opened up 10 psychogeriatric beds, that's beds for older people, and we've received funding for that ongoing. So there's been a huge investment. We're very pleased about that, and we're very grateful. We still need a lot more, but it's a start, and it's a great start, so we're very appreciative. So in conclusion, I've shared with you some of just the strategic direction, where we're going as a department, that we're clear we can't do this alone. We're clear that we have an important role. We are fully committed, and that's why we've put in our framework of intervention that mental health is everybody's business. It's no longer just the psychiatric hospital's business or Department of Health's business. It's everybody's business. And we've been seeing the support from other departments around this. It's working on the logistics and getting things moving even more so. But we've seen great progress in this area of just coming together with our joint departments in the province. And we're very excited about this space. Thank you very much.
Thank you, Ms. Dean. Sorry that you had to repeat this so soon after September of last year. Members, are there questions? Member Windvogel, Member Fry, Member Barnes. Please proceed, Member Windvogel.
Thank you, Chairperson. Let me first welcome the presentation from. It was actually powerful, and it's not like you mentioned it's not new. You were here last year, September, but with all the new stuff happening, it sounds new. Nevertheless, I must state up front the Division for Public Healthcare in the province, as discussed on slide 9, is welcome and has our full support. And we have always made those demands for our people, for a people-centric response, response of trusted and equitable public health care. However, in reality, we know this is not happening. People sleep on floors for days, and there are shortages of key personnel, and hospitals are experiencing service pressure. I therefore want to know, how far are we from achieving this goal of the right care at the right place, at the right time, as discussed in the slide? And what will the department do differently in order to achieve this? Then on slide 12, the policy needs and priorities report identifies substance use disorder as a serious challenge in the province. So one which is among the leading causes for crime. And due to shortages of rehab centers, majority of those suffering from substance use disorder end up occupying beds, space in our hospitals. And this shows the need for a whole of government and society approach, as mentioned by you. Many, I think, in the previous, in your previous presentation, you also mentioned that, so that we can tackle the problem. And I therefore want to understand what collaboration are there with other departments to tackle the drug problem, which contributes to the rapid increase on mental health cases in the province. And then on slide 70, clearly we have a serious problem of suicide in the province. How does the suicide rate compare to other provinces, and what measures are in place to respond to this challenge? Then lastly, Chair, on slide 23, I just want to check what mental health services are offered at PHCs, and why is KDH not mentioned in the slide? And what are the bed and staff shortages at psychiatric hospitals, and what measures are in place to improve on this service? Thank you, Chair.
Thank you, Member Windvogel. Member Fry, before you proceed, I just want to inform Member Baku Foster I have seen her hand. Is that for a question, Member? Member Baku.
Yes, Chairperson.
I will, if you can hang in there, please. We will then allow you to put your question after Member Buns. Thank you. Member Fry.
Thank you, Chairperson.
Thank you, Chair. Thank you for the presentation. It is well received, and yes, like Member Windvogel said, that it's certainly under trying circumstances. I have 3 questions. The first question relates to slide number 21. It couples with Member Windvogel's question about substance abuse, but I note that the schizophrenia, the prevalence of schizophrenia has increased quite drastically over the years, coupled with the increase in substance-related diagnosis. How much of the schizophrenia diagnosis is actually substance-related? So if you could break down that. Then on slide 29, the projects, it's welcome, but I see there's a project description, but no project timelines and outlines. Are those still in the workings, or do you have those timelines already? and so we can see, how that money will be spent. Then my last question is just to couple on to Member Windvogel, where unfortunately, Chair, you weren't with us at the time, but we went to Paul Hospital on a Friday night to inspect the emergency unit, and there were 16 beds in the overstay, but they could only use 6 beds because they only had 1 nurse, and there was a shortage of beds in the psychiatric ward, where we had 10 new beds just, for want of a better term, lying there. I'm not sure if you're aware of that situation, and because we resolved to call the CEO. Did we resolve to do that?
Yeah.
I think it's in one of the resolutions. On the 5th of May. Okay. So that's going to be coming shortly. But I just want to note that that's a tangible example of what Member Windvogel was saying about service constraints, and it's not all just because it's out of our hands. Some of them was within our control. So I just wanted to bring your attention to that. Thank you.
Thank you, Member Fry. Member Barnes.
Thank you, Chair. I only have one question, and my question will be on slide 20. The increased number of substance use disorder in patients is worrying. Well, last year we visited KDH and we found a number of patients sleeping on the floor, some of them, but it was overcrowded. And those patients, we were told that they were waiting for referral to Lentegeur, etc., because we know Lentegeur was full. However, I also want to welcome that at that time we were told there's a mental health under construction. There's a site that is under construction there at KDH. But what I want to know is, what is the situation like at other hospitals? For example, I've seen now on the slide before the last one, where you were outlining your projects, 4 different projects. I think it was in Neisner, when we had also one oversight where we went into one of the psychiatric wards. I think they only had 2 or 1, but it was also not in use because of vandalism, because of the patients, but they also had their own challenges right around there. What I want to know is that how do you work with those challenges in the referral system, because they also raised the issue of referral system, and what are the bottlenecks that are the bottlenecks being addressed, and how do you do it? I just wanted to get clarity, because at times we speak of KDH, and then when we get out of Cape Town, you realize that there's the same challenges and they are far from your Lentegeur. How do you address those issues? Thank you, Chair.
Thank you, Member Barnes. Member Baku Vos.
Thank you, Chairperson. Chairperson, my question is on slide 28. I would like to know what are the details of programs that have come out of this intergovernmental mental health steering committee, and how much budget is allocated to mental health through its programs, because we are really tired of talk shows. In response, in the PNP report, the staff proposed that rehabilitation centers be opened in the residential facilities so that they can be near and accessible to patients. So to what extent would the department and the Steercom support such proposals? Thank you, Chairperson.
Thank you, Member Baku Vos. Ms. Dean, I also have questions, but I'm first going to ask you to respond to those questions, and then we'll probably do a next round of questions. Thank you.
Thank you. I'd like to do my best. There's lots of questions, and I'm going to depend on my colleague here as well. So the first one is slide 9, which is, it was just a comment about a people-centric approach and equitable healthcare. So thanks for acknowledging that. Substances, I think, so we see the client who comes into our service as an acute admission under the Mental Health Care Act. And often, sometimes in certain cases, up to 50% of a ward could be for a patient who is presenting with a psychiatric illness, maybe is psychotic, but there's also an underlying substance use problem. So lots of them coming with substance problems. So we first sort out the person to get that particular person stable and then refer to a substance rehabilitation service, which DSD oversees, Department of Social Development. So we have all the resources at our disposal, but how to refer. We're working on even tightening that process between ourselves and DSD. So often they'll be in our services for stabilization. And when you say they take up our beds, they have to be there because they're mentally ill at the time. So even if they go to a rehabilitation center, it won't make too much of a difference because they wouldn't be able to engage the process. So are beds under a lot of pressure? Absolutely. Khayelitsha, Knysna, wherever you go. And the idea of the Mental Health Care Act in its purest form is that you come to a district hospital, which Khayelitsha is and Knysna is, and you come in there to have the assessment for your psychiatric condition. And once your assessment is completed, a decision should be made. Are you ready to be referred to the next level of service, which is a psychiatric ward or a psychiatric hospital, or are you ready to go home and perhaps go to an OPD service? A lot of people who have to go to the next level stay at district hospitals for longer than we would like that to be. And the Mental Health Care Act is very specific about what needs to happen. And when I said there was a one line on increasing compliance in accordance to legislation, we are waiting for a policy that limits the time that people will stay at a Khayelitsha hospital when in fact they have to go to the next level. Now, the next level is also full. Before, you could say years ago, maybe we were not as high occupancies as we have now, but we're also full. And that would mean then that the people at Lente here would have to be discharged quicker to accommodate the group coming from Khayelitsha, the group coming from Worcester to Lente here, the group coming from Heidelberg to Lente here. So Lente here's got an Amichal's plane. So Lente here's got all these hospitals coming to it. But having said that, I think there's commitment to try and work on the flow of patients through the service. That will mean then that more patients get discharged home and will be taken up at the primary healthcare level. And that is why our investment in primary healthcare is so important, so that more people, once discharged, can go and see a counsellor at primary healthcare level, can see an OT at primary healthcare level. So that would be a community health centre. So I hope that answers some of the questions just about the occupancy for district hospitals and the issue with substances. We don't do substance rehab, that's social development, but we see people in the acute phase of mental illness. And then suicide, what are we doing? I don't know the comparison between us and other provinces. We can find out if there is such a comparison. But this statistic came from our mortuary department, our pathology, forensic pathology. So they keep a list of reasons for deaths. So we can find out. But what are we doing about it? Part of the mental health steercom, which is that committee chaired by Dr. Kluti, we've made the focus of that work children and adolescents. And part of the things we have identified through our child and adolescent psychiatrist who coordinates things is that we have to do some training. We have to come up with a joint protocol across departments for how to deal with young people who present with symptoms associated with mental illness and also who suggest that they may want to consider suicide. So we want to talk about it, we want to deal with it and equip our departments across to be able to deal with it. Because you remember, children don't only come to health, they very seldom come to health, they're mostly in education. They also go to sports clubs after school. And people running the sports clubs may not know too much about mental health. So we want to equip people within those spaces on how to have the conversation, how to refer, how to deal with it, so that the individual doesn't feel so lost and alone. So that's our approach to things, and that's what we're trying to do in our 2 pilot sites going forward. So primary health care is a generalist service, but we want our generalists to start picking up mental health increasingly. They are doing it, but we want them to do it even more so. So if I come with a backache to the doctor or to the nurse, that they must start thinking, oh, is there something else here? What's your relationships like? What's work like? So we don't just deal with the backache, so that we often have backache because we have other concerns, etc., just as an example. So that's what we want at primary health care. And many of our primary health care, which is our community health centers, have a dedicated mental health nurse. Not all, but many of them. And that's what we're working on. So when the generalist can't cope with it anymore, you refer to the mental health nurse. And the mental health nurse is also supported by other professionals within the service. I think I spoke about Kalicha, and I spoke about the specialized hospitals also under pressure, and all of us must change what we do. And a couple of years ago, we haven't seen these numbers. As you've seen, it's just been growing and growing. And the problem with substance abuse has not helped, because many of our patients that we see, the stats you see here, all come in with a psychotic-related concern or a suicidal attempt, and that's why they land up in our service. These are the illest of the ill. And there are many who are ill but can get help and can return to life again at work, in the community, but they're not getting the help because they're not coming forward. It is the illest that we're seeing right now, and that's where our beds are taken up. And that's where the concerns come up with the honourable member who asked the question about the wards and how we're dealing with the infrastructure breakdowns and the damage caused. It's a daily ongoing concern that we deal with. And we can't keep up sometimes with the infrastructure changes and the new buildings, but we do our best and we try and be as dignified as we can. I think in terms of schizophrenia, our stats suggest that schizophrenia actually gets less cases for schizophrenia as we go up to 2022, and substances increase. And often we find that people come in with a psychotic episode and it's substance induced, but the more they come in for that same concern, it grows into a long-standing condition of schizophrenia. So we try and intervene as early as possible so that you don't have to come to the service over and over. If we can get you into rehab, you realize that you have this problem, you realize that you have this vulnerability, and you take control of your life, we're hoping that you can circumvent that. In terms of the projects and timelines, so we set ourselves a time in the steercom now on what we wanted to do. So we mapped all our assets as a department. So who does what in this geographic service area? So we're there. Now it's about working and referring and tightening our processes. And the projects that we displayed that's currently there, we have already started some of those projects in our last year, and it's going well. And we're seeing good effects coming from it, the psychogeriatrics, the child and adolescents. There's always going to be challenges, but we're seeing good effect from that. So I hope that covers that. Yes, let me just, yes, Miranda?
I'm not going to take it question by question, but I think just to support what Carol is saying, is with regards to the bed spaces, our biggest challenge is that regardless of what department is involved, the patient, the mental health care user, is often not taking responsibility for themselves. So when they come in with a substance-related psychosis, we have to keep that person sometimes up for 3 to 4 days to make sure that it's not. But the person goes back and granted into the same circumstances. So it's a very difficult situation, because how do you go back into an environment, and we've spoken to people where their chummies are using TIC, or the family is where there isn't. So it is such a tricky situation. They go out, they come back, they take up another 3 days of bed. So that has been quite a challenge. The other thing in terms of strengthening, so besides what Carol was saying is trying to push people up quicker, we have looked at how can we capacitate the primary health care system. And we've got our community health workers in the service. So, and I'm sorry, I'm not as eloquent as Carol, I'm just saying it as it is. But so what we did a small study in the Lentegeur, Khayelitsha, Mitchells Plain, Helderberg area. And it showed that only 11% of the people that's been discharged are really doing okay. And the reason for not doing okay is when the CHW comes to their homes, they often refuse them access. So they can't go in. The person is no longer staying there. They're back on the street. So they then skip treatment, or they have sometimes moved to another province. And then they come back and we don't know that they're back again and they're off their treatment. So it is really a whole of society issue that needs to be addressed. And I think the other thing that we have tried to put in place, and I've been involved with that, is for the suicides to have special clinics at the primary health care, special times for the children and the adolescents to come, because it's quite embarrassing for me to come if I see my friend is also sitting in the waiting room, or auntie this knows this one, and here I'm sitting as an adolescent. So if we have a special time slot for them, they are feeling less stigmatized and discriminated against. And I think the real issue that we're talking about is the infrastructure. We have had a discussion yesterday, in fact, I had with infrastructure, and it takes up to 5 to 7 years building one hospital. You have to go through the national process, and this is continuously, we do one, then we have to wait another few years for the other one. And how do we speed that up is not necessarily within the health itself, but it is how do we all take responsibility for that. So that was just, thank you.
Thank you, Ms. Dean, and thank you, Ms. Rolosa. Member Baku-Vos, I have strange visitors on my screen here, and somebody is playing around with this, really having a nice time. I don't even see my screen on this meeting now, but your hand was up. Was that a new hand or a so-called legacy hand? Member Baku-Vos, can you hear me? If not, then I will proceed on a blind screen. Ms. Dean, thank you, but it's not good news. Just for my clarity, on page 12, under the definition of mental health in bullet for point 5, you mentioned that it includes promotion, prevention, treatment, and rehabilitation. When you are speaking about prevention, I know that's a mammoth task, but what are we busy with here? And I'm sorry, I'm going to ask a very difficult question now for me, and maybe uncomfortable. What are we busy with here? Are we just in the process of not even preventing, of caring? The question I want to ask is what you are busy with, is it containable? Can it be contained at any stage, at any level, at any time? Otherwise, what are we busy with? We're just rolling over every day and every night and every year, and nothing seems to be contained within that framework as well. And I know you earlier mentioned that you don't know well, not that you don't know, it's the statistics of other provinces are not available. How do you benchmark yourself? Is there a benchmark? Is there a best practice that you relate to or compare yourself to? And lastly, what can this committee do for you? What can this committee do for you? Thank you.
Very difficult questions. Sure, it's a mammoth of a task, so I don't want to deny that. I think the first thing I'd like to say, up until now, and I'm heading for retirement, and I've been around for a while, it's the first time that we're organizing ourselves in the way that we're organizing ourselves now, as the whole of government. That's the first thing I would like to add a little bit of hope to. I think before now we worked, and we're still working, in silos. So part of what the HODs are trying to do is say, what have you got for mental health? Put it on the table. And that's where we talk about our assets, and this is the mapping exercise that I wasn't probably as clear. But we're only in a small part of the work we have to do, we're starting to do now, but it's a start. And how do we jointly start dealing with this geographic service area here, like Nyanga, as an example, rather than we all do this and we do everything for everyone and we're doing nothing. So how can we focus our attention? That's the first thing that's been positive. And then beyond whole of government is the whole of society approach. Which NPOs are you funding? Which NPOs are we funding? Which NPOs have funding? And how we're going to work together. So it's a process that we're busy with. In terms of best practice, there's been a lot of interest in the last while in mental health. And there's lots of new projects coming online. And part of what we're trying to do as best practice is to use evidence to direct what we do. And we have just started what we call the Evidence Advisory Committee in the province, and it's chaired by our head of department in psychiatry at Stellenbosch University. There's representatives from probably most of our universities locally and other researchers. And we have just started a database to say, what does research say works in this area? So it's very early days, and maybe we should be invited to come back and say how it's working or not working. So we're using, in my mind, the best minds to help direct us as well. There's been overseas interest in what we do as well. So we're hoping to gather all that and get directed. What can this committee do? I think Mr. Rulofse has got lots of ideas here next to me, I heard her saying. I think is to put us on the agenda. And I think since being on the agenda since last time, I don't know if it's a coincidence, we got a lot of more money than we've ever gotten. We need a lot more, but I think there is already support for what we're doing. And questions are asked and we're interrogated about what we're doing. The HRDs are interrogating what we're doing, and that's it's been a first for mental health. And I think this is really great news that there's just interest. It is a mammoth of a task. So thank you for the questions.
Just before I get to my real point, I think the important thing, I've been in mental health for 30 years. And I think we all went through HIV, TB, all of these other diseases. And nobody ever, despite all the requests of mental health, put it on the agenda, no one listened. Nationally, in the country, in the world, it was always down there. And I think what my sense of it personally is people are post-pandemic. It has got such a big focus, but we can't in 2-3 years, all the neglect is not going to be finished and done with. So it is going to be a process. I have seen great strides in interest from MEC, from HODs, to drive us into a better future. It's a career limiting statement I'm making now, but I think you are a kind group with lots of influence. And my personal story is that I'm a mental health care user. I've been for 30 years. And I don't want to cry. But anyway, that's not the point. The point is, I had 2 children with a very rare disease. I was 28 years old. I had a medical aid. I had a car. I had a job. I had a husband that picked up on where I couldn't for 18 months. I was privileged, put me in a shack under circumstances where I don't have money. My children had to go 3 times a week to a specialist. That same mom there, who may not have a husband that works, who may not have a job, who may have a husband on substances. How are we going to help them? And this is where you are, because we can only do this. But the whole of society and substances and poverty. Sorry, this was not to be. I've never shared this in a group, sorry.
It was on. Thank you, Mrs. Dean and Mrs. Rulopsa, for being so open and so honest. It's touching, but it's also very, very real. And maybe you've just opened the door a little bit more than it was open before. So thank you for sharing. It's most thoughtful. Thank you. Members, are there more questions? Member Plato and Member Fry? Member
Chair,
Van Voorthuizen?
maybe not really a question, is maybe just confirmation from the 2 ladies. And I think the presentation today is a result of us visiting some of the mental health facilities and observe and see. Vir my was dit die plekke is net oorvol. And I think that is part of the reason why we wanted more updated information, but the updated information is just dramatic, as if there is no end in this regarding the situation. I'm glad to hear about increasing budget and that sort of thing. We hope it will work and help. But it seems to me issues such as hunger, food insecurity play a major role. People's tummies are empty. People resort to other means. Youngsters go and sell rather drugs and things like that to make the ends meet, to buy food and that sort of thing. It's a vicious circle in our communities. You mention primary care is provided to a defined community. What is that defined community alike? I think that is important, and I can sketch a picture in my mind, the poverty-stricken and poor and that sort of thing, without nothing. I might be wrong. But I like what you are saying. I think it's on page 30, one of your last pages, looking at the fourth bullet point. You're talking about a redesign of service provision is needed. That is so important, Chairperson. The question is, have you started with that? What is the HOD? Is he supporting that? And when will we hear and see much more about that? But my last point is COVID, obviously with factories, businesses closed down. Poverty aggravates the mental health situation. I think maybe that is the part of the reality. Thank you, Chairperson.
Thank you, Member Plato. Member Fry, and then Member Windvogel.
Thank you, Chair. So I forgot your name. I'm not really good with Mirinda. Through the Chair, I just want to say thank you to Mirinda for her bravery and her courage. I don't think it's a career-limiting move, and it shouldn't be. Because I too am a mental health. I have a manageable condition. But like what Mirinda said, she's got a job, she's got a car, she's got a health, she's got a medical aid. And I too have medical aid. But there was a time when I didn't have medical aid. And that was a very, very difficult time, because medication is not cheap. And I think that we have to be mindful of that. That this is the extreme, like Member Plato was saying, these are the extreme conditions that our people are under. And I think we must work together, like Mirinda said, that we are kind and we will ask the difficult questions, but it's not out of malice. It's out of a deep, deep sense of wanting to serve our people. I just have one more question, and it's about the revolving door syndrome that we saw at again. Sorry, Chair, you weren't with us at the time, but it was a game when we saw at Falkenberg and Lentegeur when we went to go visit those hospitals, and they said that apart from resources, which everybody wants, the major issue was that the revolving door, and they need awareness programs, and they need to work together with Department of Social Development chiefly. But I want to ask, what is this department doing in terms of what can they do in terms of mitigating the sense of the revolving door syndrome, which is where people go when people leave the facilities and they're not given the necessary support and they come back. So what is the department doing there? Thank you.
Thank you, Member Fry. Member Windvogel.
Thank you, Chairperson. Chair, as ek gaan nou sê 'n riem onder my hart, want ek besef dat ons het officials, ons is lief om te sê jy het officials, ATM officials en jy het ATM politicians. And I realize in the team there's officials who understand the pain of the pain of mental health. En dit bring die riem onder, is dit die regte Afrikaanse woord is onder my hart, wat vir my eintlik baie moed gee, en ek het hoop, dinge kan verander. Because you have officials wat verstaan waardeur ons kliënte, ons pasiënte gaan. And so you will do that extra, of jy will go that extra mile to assist them. En dit is really, dit bring, dit is regtig 'n riem onder my hart. Dan, Chair, ek dink die officials het gemention dat there's this positive vibe in this, rondom hierdie nuwe babietjie. Remember, health and wellness was not part of health. It's a new baby for health. They are getting more funding, and the issue of the whole of governmental and society approach it's a bit of a problem still, but there is a move. Because what is important for me, and I know what I realized, the move is somewhere up there, but down here, there's nothing happening. And I think that's why the chairperson said, what's a vraag? Difficult. It's not that they want to be difficult, because we want to see change. And we want that change to be down there where the problems is. And if we look, I think we have a discussion after our previous oversight visit to these different psychiatric centers, is that we need home affairs, we need police, we need social development, all those departments to make, and our community NGOs to make this, to make it work. Now, there's no support structure. You mentioned when I'm not sure who mentioned it, was it one of our members of you? When someone are just discharged, where's the support structure? It's going back to the same environment. But there's no support structures. I know in the previous years, we have, wat noem hulle, die mense wat alcoholiste is, dan het hulle die supportgroep in die gemeenskap, wat gedryf word deur NGOs. Why don't we have such support structures in our community? I'm just putting it on your table because you are the people who need to drive this. So because I know about specific cases, I engage the social development, they assist, take the youngsters and the people in, but they have to discharge, even they are not ready to be back in the community, but because there's no space, they are sending them back, and 2 months, not really 2 months, the person is back in the system again, because we are not treating them because of space. So yeah, I really want that movement up there with this governmental and society approach. I want it down there in the community. Thanks, Chair. And lastly, Chair, I'm not sure, is it part of my recommendations? But I really want to, is it possible that we can get a list of NGOs in the Western Cape that you are funding, who are assisting, or who are giving you this type of services?
Thank you, Member Van Vogel. I don't see any other hands. Over to you, Ms. Dean.
Thank you so much. The list, I'm sure we can do that, if we could just get some communication. So I think both honourable members spoke about the revolving door and the after support for that. There's so much to talk about in mental health if we go into the detail, and we'll be here all day. So we really appreciate the questions. We have gotten, as Department of Health, a lot better at our data. And I think, again, COVID, we just got pushed to new heights. And that has happened even in mental health. Like Miranda was saying, often mental health is kind of left behind. But we had a public health registrar working on what we call a dashboard for mental health. So our data is so much better now. We're working on other areas like child and adolescence. We'll be able to see more closely what's happening there. So we really appreciate that investment, but that's at facility level. And work that we've been doing, and Miranda and some of our colleagues, we're trying to look at when the person gets discharged home, how can we track, how can we keep a focus on the care for that person? So there's an app we're busy testing. One of our doctors at Mitchell's Plain developed this app, so we're looking at that. So that will help immensely, because it will say Carol Dean did not go to the clinic. Carol Dean has not picked up medication. We want to get to that level. We also have in our data space something they call the single patient viewer. So I can track where Carol Dean has gone, if I'm a clinician, to see when she's connected with the health system or not. So we want to get that smart that say if you were living, I'm using an example now in Heiderveld, and we see that you've come in with an acute admission, but you're now discharged home. We want you to see the mental health nurse. We want you to be serviced by the community health worker, but it's not happening, that we have an approach for you as an individual. We're not there yet, but that's the resource that we have access to and that we want to start utilizing. But health, remember, does health, and we're doing wellness now, but that's how people come to us, and we're really shifting their gear to go to people too and make that connection. And when I say the community health services has been there for a long time with other medical care, it's now including mental health. It's very new. So we're starting to just place that more firmly. So the work we're doing in the SteerCom is to get to this point where you have all departments sitting around the table and say, the youth in this area, if we use Nyango or Heiderveld, they don't have options after school, or they're dropping out before school ends. What we're going to do about it as the whole of government. Or the youth don't have university access or college access. What are we going to do about it? Because like Miranda was saying, to put people in the same situation and ask for a different response isn't very smart. So this is where we're trying to build that intelligence. And I think that is what we understand as our WOGA and WOZA approach. And there's a process now, a discussion of authorizing people to work on the ground. It's not optional. It's not a nice to do. Because often you get leverage from the fact that I know Miranda, so she'll do me a favor and see my patient, or she'll put him on the list. But we don't want special favors. We want everyone to try and get a standard that we can all feel proud of. And that is the process of our HODs starting to mandate what we do on the ground. So I think there's that process, and there's other processes politically and otherwise that's supporting this approach, but I'm not at liberty to go into the detail of that. But I hope I answered the question around the revolving door and the aftercare. So we're already investing in aftercare services in the communities through support groups. Probably not sufficiently and not at the level we should, but that's the idea, to try and get people retained in care when you need care. If you need to be adherent, how do we keep you adherent to your medication, your care, your therapy, rehabilitation, so that you don't present again with an acute episode? How do you encourage people not to take substances? And that's the work that we're trying to do in the promotive space and the prevention space. So this year, as in April of this year, that's going to be our focus going forward now. We're working with all the departments we're working with and communications and our experts in this area. So that's where we're at. Thank you.
Sorry, maybe just if I can add one last thing to what Carol is saying, is that, so Carol goes to the SteerCom meetings, the more upwards side. I'm more on the operational side. And I think what we do expect the community health workers is to respond within 72 hours after discharge. And then there's a link with the PHC facility, so that if the person doesn't pitch there for medication, there's communication backwards and towards, so that we can then make sure that we start preventing, and retention and care is better. So it's a minor bit. I think also at my level, there is starting to have an intersectoral group with DSD and education, where we really sit with the problems and say, how are we going to work together? So although there's up there a broader platform, there are the smaller bits and pieces that we're trying to work with. It's not 100%, but I think it's a start of a process. Thank you.
Thank you. Are there any more questions, members? Online, Ms. Member Baku-Vos, or any other members that are online? It doesn't look like it. Well, with that...
Chairperson.
Yes, Member Baku-Vos.
No, I don't have any question, Chairperson.
Thank you. That was loud and clear. Ms. Dean and Ms. Rolofse, thank you so much for your presentation and your openness about the challenges that this specific discipline requires and is putting you up to the challenges. I don't think I can begin to comprehend how much steel you must have in your blood and in your minds to be able to do this day after day. But I applaud you for that on behalf of this committee. And I wish you every strength and every success in all your endeavors. And I don't think you should retire now. We need you. I think, members, let's take a short break and have some refreshments, and then we'll. But I have to say goodbye to you now, because after that we come back and you go wherever you need to go. Thank you very much.
Yeah, just want to say thank you very much, and just thank you for the acknowledgement of us, but also to our staff, but also for the work that you do, and thank you for having us.
Please convey our gratitude to the staff as well. No, that's life. Sorry?
They must join in the members' lounge.
Yes, of course.
Chairperson, my hands is up.
I'm sorry, Member Baku Vos. I didn't see that. My apologies. You are welcome.
Thank you, Chair. No, I thought we were going to do resolution before we break.
Shall we do the resolutions?
So that we know we are done.
Thank you, Member Baku Vos. We'll do that. Shall we do the resolutions now? Fine.
I'm proposing that if other members agree on that.
We agree.
That's fine, Member Baku Vos. That is fine. Do you have a resolution?
Thank you, Chairperson.
Sorry?
I think we just give them time to leave so that we can do it.
Are you going to join us outside?
In the members' lounge.
In the members' lounge.
There are refreshments.
We won't be long. Thank you. Thank you. Member Baku Vos, do you have a resolution?
No, Chairperson. On my side, Comrade Rachel will give the resolution.
Thank you. Members, we will now ask for resolutions. Member Windvogel.
And die leier het vir my geïnstruct om te lead, so I will do that. Chair, I think one of mine was captured, and then the second one is, I'm not sure, Nomonde, because you are the person taking notes. There was and Member Fry, Member Buns, because the chair was not with us when we went and do oversight. When we visited those centers, hey, die woord, die tong, daar was a lendigeer, I think so. But there was this request from those people by saying, we need a meeting with the different departments who's giving them problems to do their job. I'm not sure.
It's lendigeer.
Yeah. So I'm not sure, because
they want social development to meet with them.
Mama, you asked me to lead. so my
Los Tandwa bendikhumbuza ndivubuza.
Diabulela. So my request, or my not request, I'm off now, but yeah. Yeah. What I'm saying, or what I'm trying to say, is that my understanding of, I thought today's meeting was about that we will have, it's just it was my understanding. So it's this type of meeting. Where we have social development, Home Affairs was one of them, police was one of them, which one? Social development was one of them. That was a request from the managers in those facilities, and even at hospital level where they are having patients. So I want you who are clever to formulate that in a recommendation. Ayanda will it formulate.
Member Barnes?
Thank you, Chair. I'm not far from what Member Van Vogel is saying, but I think as this committee, we've done very well in keeping the department accountable, especially on mental health. I just think maybe we should have a resolution that says that in this quarter we are going back to visit at least here in Cape Town, not far. We go back maybe to Khayelitsha or to Lentegeur to check on progress, just for accountability. Remember, we've been there, and then we got a report of this construction that is happening. We've seen it, and we don't have any challenge with it, just to measure so that we keep the pace of keeping the department accountable. Mental health has become something that we didn't see that is going to be massive. So we should keep our hands on the pulse. That's my recommendation that I wanted to make. To say, let's go at least once to Khayelitsha or to Lentegeur, the ones here in the metro, and pay a visit so that the department can see that as this committee we mean business on wanting to curb what is happening with mental health. I just wanted to raise that one. Thank you, Chair.
Thank you, Member Barnes. Member Fry?
I'd like to add into what Member Barnes has said, that we make those visits unannounced again, so we can like Member Barnes says, that we can show the department that we're serious about our oversight role. So yeah, I just want to make sure that we do it unannounced.
Thank you, Member Van Vogel.
Yeah, we are not done with my. I'm not sure if you are agreeing with me. Because that was requested, it was actually one of our resolutions then in terms of getting those departments in one room. Because what they are saying is that health is saying whenever a child who are addicted to TIC is throwing out windows, trying to beat someone or doing stealing or whatever, the police will take him, bring him to the hospital. It becomes our baby. So we need to engage the police on this issue. Whenever they need to send a patient to rehabilitation center, they need something from the court or from the Home Affairs. So I want us to really go and really look what was said then in that minutes with our oversight. But there was a request that we need to meet with all these different stakeholders in making the life of those officials easier in order to give the service to our people, to service our people.
Thank you, Ms. Van Vogel. I'm sure that's been captured sufficiently. I think what we need to do is to just go back to that original resolution and take it from there. Are there any more recommendations or resolutions?
Just a comment.
No, Chairperson, I just want to add on what Honorable Van Vogel has said. Really, because what happened in that Lentegeur, there was a cry from the management that social development is not, they are not hands-on. Whenever they need them, they are not there. So we reported that to the social development, what happened in Lentegeur, and the minister promised and said to us, no, they are busy with that. So we just need really to visit that, and then we can cluster all those mentioned committees by comrade, by Honorable Van Vogel, to do a cluster visit. I think cluster visit will be better. But in this time, if I'm right, we can do to them an announce visit so that no one can say, no, we didn't come prepared, because we want to know, after we reported the matter to them, what did they do to follow up the matter? Thank you, Chairperson.
Thank you, Member Baker Vos. Member Plato.
Chairperson, thank you. Just to link up with the two honourable members, the last page, and that was part of my just comments on it, not really a question. It brings us back down to the one critical element or issue, the whole of society approach. Who must initiate the whole of society approach? All the entities, even NGOs and that sort of thing. Maybe we need to get a sense of who's the NGOs operating in this field? What are they doing? Maybe that could become another recommendation. We need to hear from the NGOs. They have their stress levels as well, or stress issues. And I understand maybe I'm going to open a can of worms, because NGOs will come here by saying we don't have enough budget. That's number one. But if you say you need assistance from these entities, what are they doing? How are they doing it? And I think we need to begin to listen to that as well. But I agree fully with Member Van Vogel, the issue with regard to our own entities in government, health, social development, what are they doing on its own to address these issues? But then they can address these issues, but if we don't address the other underlying issues, such as poverty, I think the big elephant in the room is poverty and how we address poverty. Thank you, Chair.
Thank you, Member Plato. Member Barnes.
Chair, I don't want to exhaust the topic, but I think I also want to add on to what the members have said earlier. I think if we move forward, I was not part of the meeting in Lentagere. I think it was the time I was at maternity leave. But either way, when I listen to what members are saying, is from what they got from Lentagere when they were there, that they don't get cooperation from other departments. I think as a standing committee, we are also fortunate to be serving together as on the STC on the different portfolios. At some point, maybe the officials, they can't find each other. If we can create a platform where we bring them with the executive. The executive are ministers. They are not there every day in the working space. They are also like us members. So maybe they are not even aware that these officials can't find each other at the working space. If health is saying we are trying to reach out for social development, but we don't get them, it's not that it's the fault of Minister Fernandez. It's amongst them. So maybe they are not aware. If we create an environment of saying today we'll have the STC meeting with them, we invite them to Lentagere, then we have Minister Fernandez, we have Minister Mbombo, and whoever minister that, because it's assisting us, it's assisting the entire cluster to address the challenge that we are having. So my suggestion will be incorporated to what my colleagues were saying, that let's create a platform, but my request in this platform would be, let's go back to Lentagere and invite our executives as well and have a round table, because it's not that it's a big problem. This one can be solved very easily and quickly. Thank you, Chair.
Thank you, Member Barnes. Any more resolutions, recommendations? Thank you. Members, then shall we complete this meeting?
Yeah.
And then go to the members' lounge?
Yes, I agree with that.
No, it's just that the reason I didn't want to keep them waiting for too long, but that's fine with me. We will then move on to item 10 of the agenda for today. Item 10.1, the draft minutes of our meeting of the 23rd of March. If we can go through that on page 1. Are there any comments?
Chair, I went through the minutes and I'm okay with the contents.
Thank you, Member Plato. Page 2. Page 3. Can we have a proposer for the minutes to be accepted? Member Plato, and seconded by Member Fry.
Yeah.
Thank you, Member Fry. Members, then lastly, on the program for today is the draft committee program and the logistics for the Oberberg visit. I'm going to hand over to Ms. Jamche for the Oberberg visit, which is planned for next week, if I'm not mistaken.
Yes. Thank you, Chair, through you. The visit to the health facilities in the Overberg, to Boland region, which is, I think the committee is going to visit Nongobela Clinic and Ashton Clinic. The visits are going to be unannounced. So the suggestion was the committee must depart on Thursday after the house sitting. Or members, if I don't know what I must say.
Say it.
Okay, so there are two options. The committee is going to sleep over on Thursday in Boland, in Robertson specific, for the visit the next morning to Nongobela Clinic. And also there's also Robertson Hospital. There's a hospital there. It's just 5 minutes from the clinic. The committee is going to visit Nongobela Clinic, the Robertson Hospital, and the Ashton Clinic. Those are the three facilities. So the advice was, or the suggestion was, the members can leave from WCPP to Robertson after the house sitting, or members can leave maybe after the caucus, then join the house online. I don't know, that is just an option. It's up to members whether they want to leave after, because if we don't know what time the house is going to adjourn on Thursday.
We can leave early the morning.
Thank you, Ms. Jamche. The option obviously is to leave very early the next morning as well. Since it's an unannounced visit, we don't have to be there 9 o'clock sharp, so to speak. That is an option, that we say leave at 7,
yeah.
and then we should be there within 2 hours in Robertson. Also, we're driving against the traffic. We're not driving into the city. If you could perhaps let your wishes, as far as that is concerned, known, or shall we decide now? Do you wish to sleep over, or do you wish to leave early on the Friday morning?
My feeling is that we need to sleep over. Remember, we are driving into the traffic in the morning.
We're driving.
I'm driving into the traffic from Blouberg.
Oh, you mean
to Cape Town.
You have to, yes.
And then we have, for 1 day, we have to visit the clinic, the hospital, drive to Ashton and visit that. So what time are we back? And I need to go back to Swellendam again.
I think the matter is what time do we depart on the Thursday? That's the issue here, and that is what is unclear at the moment. Do we leave before the house sits, and then join online? In order to do that, we would have to leave by 12 o'clock at the latest to be online, or we leave after the house meeting, which we don't know what time. Let's just see. On Monday, I will find out from the.
I'm proposing that we leave at least after the caucus, which is 12 o'clock.
Thank you, Member Bakabakafos. I will find out on Monday morning what the likelihood or the possible program is, and then for Thursday, and then we can make a decision, if that's okay with you.
That's fine.
Thank you very much, members. Ms. Jamche?
Okay, the other thing that I want to is
I think Nomondo was going to go further because there is another proposal that we visit Lindela in the house of Mamu Cynthia, the place that she's staying is not the house, Mamu Cynthia place.
I didn't hear that.
Okay. Member Bagu is saying that maybe the committee, while the members are on that side, since it's the same members for social development and health, maybe they can visit her site, which is the site of Miss Cynthia Bless. I don't know where that site. Where is that?
Is in Wittenberg. Lindelani Place of Safety is in Stellenbosch.
But those visit members are going to have their own date for social development, because this visit, if we are going to visit 3 sites on the same day, especially on Friday, it's going to be too much. So social development will schedule those 2 visits and conduct the visit for social development. Yes.
Okay, no problem.
Thank you.
So in terms of logistics, because I've sent a request, Chair, already to logistics for accommodation, are all members that are here attending going to use accommodation on Thursday? Can I book accommodation for all members?
You must just establish with the member class whether he will be accompanying us.
Will.
But yes, then we do it like that. Is there agreement on that? If we leave on the Thursday?
Yes.
But then we will have to decide that early on Monday morning.
Yes.
So that we can proceed.
Yes. Okay.
I think if you are pressed for space, you might as well do a provisional booking today.
No, I think I just saw something from supply chain. Maybe it's their quotations, because I've requested quotations already.
Okay.
I'm going to now just confirm that members are going. So once the quotations are signed off, members, please come, because if you don't come, we are going to pay the money, unfortunately. And I wanted, Chair, to also talk about the meeting of the 28th. We were supposed to have a visit on the 28th to Boland, to Paarl, but that visit now has been postponed, moved back to the 5th of May. So the 5th of May, we are going to have a follow-up visit to Paarl Provincial Hospital. The visit to Paarl is a follow-up of the last year visit. So the one now that we are going to have on the 5th of May is going to be announced so that the management can prepare presentation and wait for us. We'll focus more on the service pressure areas, the bed space, and the services that they offer based on the previous report that we received. That's all.
Thank you very much, Ms. Jamte. That's very thorough. Thank you. Members, with that, I think if there's nothing else.
Then the NHI also.
The NHI.
Yeah, also in the program, there's an NHI. After the visit to Paarl, there's a provisional date for NHI. The briefing is going to be the 18th of May, because the National Department is going to brief the NSOP at National on the 16th. So when it comes into it, the NSOP bills, it's a first come, first served basis in terms of presentation. So for Western Cape, the date that is for the briefing for the NHI is going to be the 18th of May, but we are still waiting for the bill. They only email us the program for the NSOP, and the actual bill, they said that is still with their legal. So I will let members know if that meeting of the 18th is going to take place or what.
Thank you.
Thank you, Ms. Jamche. Thank you very much. Members, if there's nothing else to be added, we will adjourn this meeting. Thank you for your attendance. This meeting is adjourned.
Thank you.
Thank you, John. On Monday.